Hello, I'm Charlotte Coles, and I'm delighted and honoured to be speaking for the motion 1 week of whole breast radiotherapy is the new standard of care. I have no disclosures. So I'm going to cover 4 key themes that provide the evidence to support this motion. So that is scientific rationale, clinical trial results, rapid implementation, and global patient benefit. So for the non-radiation oncologists, traditionally 2-gray daily treatments or fractions have been used, and anything bigger is called hyperfractionation. And this results in less treatment visits for the patients. So let's start with the scientific rationale. And in fact, the words of Gilbert Fletcher as true today as they were 30 years ago. And these were that hyperfractionation should not be used unless there's a specific rationale concerning the tumour characteristics. And this really strong statement was prompted by a serious harm suffered by patients with breast cancer in the 1970s and 1980s. And this included brachial plexopathy. And it was a result of new hyperfractionated regimens based on theoretical radiobiological model being adopted into clinical practice to solve a resource issue. And this is without testing within clinical trials and without the essential quality assurance. So Professor John Yarnold was another clinician who was also fully aware of the possible harms caused by inappropriate hyperfractionated regimens. But he discovered a paper in the early 1980s that looked at old clinical data from breast cancer radiotherapy and applied it to a new radiobiological model. And this showed quite startling results. So it suggested that breast cancer is as sensitive to fraction sizes as late normal responding tissues. So if this is the case, then 2-gray fractions spare tumour and normal tissues equally. So there's no advantage, and that larger fractions should be worth testing within clinical trials. So this was the scientific rationale that was required. So John Yarnold was also fully aware that the previous serious problems caused by breast hyperfractionation was due to the total dose being too high. And this must be reduced in order to prevent an increase in the late normal tissue toxicity. But the big scientific question was by how much? So a series of randomized clinical trials ensued both in the UK and in North America. So breast hyperfractionation research is, of course, an international success story, but I'll be focusing more on UK examples. And it's really important to point out that breast cancer hyperfractionation is not a new treatment. For example, in the UK, we have over 30 years of experience of high quality practice changing trials that have dovetailed with over 15 years of risk adapted hyperfractionated radiotherapy. And this is all underpinned by our centrally funded UK radiotherapy trials quality assurance programme. So the START-B trial was one of a suite of breast hyperfractionation trials and had a pragmatic design comparing the then international standard of 50-gray and 25 fractions, which was mostly used in the south of the country, compared with 40-gray and 15 fractions, which is mostly used in the north. And the 3-week regimen was predicted to be radiobiologically equivalent to a gentler dose of 46-gray in 23 fractions. And you can see with the forest plot here that 40-gray was certainly gentler on normal tissues with less side effects. What was surprising was that it was not gentler on the tumour, and non-inferiority was proven. And this raises the possibility that the overall treatment time is an important factor for breast local regional control, and shorter regimens may compensate for potential tumour repopulation taking place in weeks 4 to 5. So the next big question after START-B was testing the new UK standard of care of 15 fractions with 2 different dose levels of just 5 fractions. and this is within the Fast Forward trial. So the reason for the 2 dose levels was to determine the isoeffective 5 fractions dose for both local control and normal tissue toxicity. So the primary endpoint was ipsilateral breast tumour relapse, and this was reported in April 2020 in the Lancet with a median follow-up of 6 years. So this was a phenomenal effort with more than 4,000 patients recruited from over 100 UK centres, and the target accrual was actually reached 2 years ahead of schedule. And this is probably helped by the RTQA set in place by the preceding import trials, and a huge enthusiasm from patients to participate. So this is the primary endpoint, and you can see that there was no difference in the relapse rate between the trial groups, and non-inferiority was met. You can also see from the vertical axis truncated at 3% that overall relapse rates were very low. So this slide shows the clinician in purple and the patient assessments in green, and the darker colours represent moderate to marked normal tissue effects. And you can see across all groups that the moderate marked effects were low. And there was a statistically significant increase in late normal tissue effects for 27 grey, but the effects are very similar to control for 26 grey. So here are the conclusion. It shows that both 5 fraction schedules are non-inferior to 40 grey and 15 fractions for local control, but for late effects, 26 grey and 5 fractions was similar to 40 grey and 15 fractions, and 27 grey is more consistent with 50 grey and 25 fractions. So there was obvious benefits to both patients and healthcare systems, and potential huge savings, but also this regimen of just 5 fractions was particularly important during the COVID pandemic, and I'm going to come on to that later. So what I want to do now is cover potential concerns around the 5 fraction radiotherapy and try and bust these myths. So the first myth is around acute toxicity. So this slide shows the red being 40 grey, the blue being 26 grey, and the green being 27 grey. And the top panel with the solid lines shows grade 1 reactions, and the dashed lines show grade 2 reactions. And right at the very bottom next to the horizontal axis are a tiny number of grade 3 reactions. And this confirms the radiobiological assumptions that acute normal tissue toxicity is related to total dose, which of course has to be reduced in hyperfractionation, not dose per fraction. And you can see that with 5 fractions, not only is the treatment shorter, but the acute effects are milder and settle quicker. And this is a huge benefit for patients with breast cancer who want to get on with their lives with minimal disruption. So the second myth is around late normal tissue toxicity. So the clinician reported late normal tissue toxicity effects here have been divided into 27 grey in green and 26 grey in blue. And breast induration outside the tumour bed and edema have been highlighted, but of note, the only statistically significant result for 26 grey versus 40 grey is for breast induration. It's then important to look at the absolute treatment effects in order to determine clinical significance, not just statistical significance. And you can see here in the table by the side that the percentages for the absolute treatment effects are tiny. So you can see here that the same data, but illustrated graphically, and you can barely see the pink and purple of the moderate marked edema, as that they're only present in 1 to 2% of patients. So the third myth is around length of follow-up. So do we need to wait 10 years follow-up in order to change practice? I would say that the simple answer is no. Of course, it's good practice to continue follow-up beyond the primary endpoint so that we learn as much as we can from every patient within a single trial. And we try to do this with all our UK breast radiotherapy trials. And as a result, we've learned that normal tissue toxicity increases with time, but it happens in both arms of the study, as seen here with the START-B trial. And you can see quite clearly that the curves remain parallel and they don't diverge. So this is also illustrated in the 5-fraction FAST trial, testing 5 fractions once a week over 5 weeks, which showed remarkably similar hazard ratios for late normal tissue effects at both 5 years and 10 years. So what about myth 4, the effect on larger breast size? So concern has been voiced that there may be increased late normal tissue toxicity using 5 fractions for women with larger breasts. But if we look at data from more than 4,000 women in the Fast Forward trial, many of whom have larger breasts, as the UK does have a substantial obesity problem, you can see that adjusting for breast size made very little difference for the clinician assessed and the photographic assessed normal tissue toxicity endpoints. So the 5th myth is centered around radiobiological concerns of triple trouble. So for the non-radiation oncologists, double trouble is when hotspots in the radiotherapy plan using 2 gray fractions both increase total dose and dose per fraction. And this could potentially cause increased normal tissue side effects. And triple trouble is the same concept, but using hyperfractionation. And you can see from this table that the predicted radiobiological differences are not a concern. However, what's much more powerful is using real clinical data. And this was looked at in the 5-fraction FAST trial using the 2-year photographs. There was no significant difference between the test groups and control. And then when the hotspots were then interrogated and controlled for breast size and surgical deficit, there was no excess risk due to triple trouble in the 5-fraction group versus control. So it also reinforces that, of course, we need to give a good quality assured radiotherapy and limit dose inhomogeneity. So the last myth is centered around the effect of 5-fraction radiotherapy on subgroups. So this slide shows the number of events and the number of risk in the higher risk subgroups within Fast Forward. And of note, more than a third of patients were considered higher risk, either because they were less than 50 years or had grade 3 tumours or had both. So here's a subgroup analysis of the ipsilateral breast tumour relapse within the Fast Forward trial that's been analysed according to subgroups, 26 grey versus 40 grey. And what you can see is that the confidence intervals are very wide due to few events, but there's certainly no suggestion of difference in local control for different subgroups. And this also reflects the results of the large meta-analysis that's been carried out for moderate hyperfractionation. So implementation of 3 weeks of radiotherapy into standard of care has taken more than 10 years. So a positive effect of the COVID pandemic has been to unite the international interdisciplinary oncology breast cancer community to come together in solidarity and share protocols and experience and reduce the risk so that we can reduce the risk of exposure of patients and staff. And this included the Fast Forward trial that was submitted and published during the first wave in 2020. So this slide shows the UK national radiotherapy dataset on the breast radiotherapy activity, and this includes both whole breast and nodal radiotherapy. And this was during the first COVID wave. So the teal colour shows use of 5 fractions, and you can see that it was less than 10% back in February of 2020, and that it peaked to around 90% in the April-May, and then settled down to over 60% in early summer, where it's now remained. So in October 2020, we held a UK virtual consensus meeting, which brought together 55 of the 62 radiotherapy centres, and they attended to discuss and vote on the consensus statements. And the main statements are summarised here and have since been published. And you can see that 5-fraction radiotherapy has been embraced as part of standard of care in the UK. So the rest of Europe are not far behind, and we've completed a consensus on breast hyperfractionation using Delphi methodology, and this has been led by Ikro Mirtili, and it's been accepted for publication in Lancet Oncology. And the consensus statements reflect that no more than 3 weeks of radiotherapy should now be offered, and have a permissive approach to 5 fractions, whereby 5 fractions can be used as standard of care for many patients in many countries, but further trials for those countries still with equipoise can go ahead as well. So finally, I'd like us to consider the potential global patient benefit of 1 week whole breast radiotherapy as standard of care. So I've been fortunate in chairing the Lancet Breast Cancer Commission for the last 5 months, and this has really opened my eyes to the huge issues globally for people with breast cancer. And an important one has been the lack of access to radiotherapy. So this map shows access to radiotherapy machines worldwide per million population, and the dark green represents 5 or more machines, whereas the lightest green represents 0. So you can see that there's stark disparity with huge swathes of the world having very limited or no access to radiotherapy. So here's the same map showing in US billion dollars the existing investment in radiotherapy machines in red, and the additional investment needed in blue. So if the current trend continues, it's estimated that by 2040, around 60% of the 3 million new cases of breast cancer per year will be in low and middle income countries. So it's our moral duty as a community to think globally and put in place international breast cancer guidelines that support 1 week of whole breast radiotherapy. As the effects of this could be game-changing in addressing this rising inequity and have knock-on effects of saving lives. So in summary, I'd like you to consider the following: the strong scientific rationale, which is now proven, clinical trial results, which show really robust data built on 3 decades of high-quality clinical trials, rapid implementation that's been facilitated by international collaboration, catalysed by the COVID pandemic, and we've really got to keep up this momentum. And global patient benefit. So it's now a realistic goal that every patient will have equitable access to high quality hyperfractionated breast radiotherapy. So in summary, is 1 week of whole breast radiotherapy the new standard of care? So I would say, if not already, it certainly should be. So I'd like to acknowledge the funders, the sponsors, and the huge multidisciplinary effort from the breast radiotherapy community right across the UK for the Fast Forward trial. But most importantly, I'd like to thank the 4,096 patients who were brave enough to put themselves forward and give other future patients the choice to have 5-fraction breast radiotherapy, regardless of where they live. So thank you very much for your attention.